And that's really what they're looking for to make sure. I'm trying to think, I can't think off the top of my head what some of the ones that were that we did for peds. One of the ones was the Synergist in peds. It's for the premature babies, and so they would give them that medication. And so preemies typically have so many more difficulties because they were so small and little and preemie that this medication helps them to stay stronger and their lungs stronger or something like that. And so they were measuring, how many hospital visits did their preemies have over a certain period of time as opposed to when they started doing this process, right? So they could see that cut it down because they were able to fight off infections a lot better, things like that. So it's kind of interesting if those of you who like that type of thing can think about some things that you have worked on that you're not really thinking was a big deal, but it might have been something that you worked on and you saw some improvement in some patients. We can actually use something like that as a quality improvement across the board, things like that. Vulnerable populations, I know typically what my practices use on vulnerable populations, because the reporting is really good and they are vulnerable, are our Medicaid patients, but you don't have a whole percentage of Medicaid patients, but you can still use them as your vulnerable population because they are still vulnerable. Or you can look at that as a demographic. You can look at that as, older or younger folks. You can look at this as male or female. Sometimes we see a lot of the males that are, 20 to 30-year-old range that don't have insurance, so they're vulnerable because they can't afford to come in. So, how do we get them in here and how do we get them to pay? And now with the new healthcare plans, we're going to be able to see some of those patients coming in that we hadn't seen in a while too. That might be something to set a goal for,
I just came up with, I noticed for the last 2 months, we hired a person who actually has access to system Medicare, who is reviewing Medicare patients, and she's able, what's her name, Ms. Wardy. She evaluates expenses related to Zostavex and DTaP. Because those are the immunizations we don't do on an annual basis, we're forgetting. There's a person who actually day before reviews our schedules and sends us a flag. So when I see the patients, I click the flags, pop-ups, and there is a price for Zostavex and DTaP. So it kind of reminds me to offer this.
Yes.
And this is helpful because large amount of patients for the last 2 months is getting DTaPs and Zostavex.
Okay.
Medicare patients.
That's a great one. That's a great one. Yeah. And then there's guidelines behind why we're looking at that, right? So those are the guidelines that we would be, needing from you all as to where do those guidelines come from, and is everybody seeing that same information for their Medicare patients? So that's great. That's a great one. Yeah. And so you're already doing it. Now whether you can measure that against anything from the past or not is kind of hard. I don't know. But the Medicare person that person may have that data for you, so you can use the report from the past and compare it to what you're doing now. Because obviously, if that's something that we're looking at and making sure of, there's got to be some improvement. Right? So anything like that you've seen, that's a really great example. Yeah, that's perfect. And then number 4 on 6C is really interesting. A lot of practices say, what? We're going to invite the patients and the family in our quality improvement team. Who does that, right? But it's actually very interesting when you bring your patients in. And you can pick who they are. You don't have to, it doesn't have to be hard. You don't have to bring the favorites in, if you know what I mean. The frequent flyers, you don't have to. You're supposed to look at a diversified group, so try to do that. But bring them in. You need to bring them in as often as you feel like bringing them in, but at least during your the period of time that we're measuring. Let them come in, ask them some questions about the practice. What do you think? And it can be from various locations. How are we doing? What do you think? What do you think of the practice? Is there anything we could do better? And you'll find that they're very open about sharing, and not in a mad kind of way. We've had some things that people say, I don't mind waiting, but your lobby chairs are really uncomfortable. It's crazy, right? Or they're old, and can you get new chairs? That kind of thing. Something very simple. And so what we're finding is, what you can find on these is that somebody has a need, and whether you can improve on that or not is the question. And then you try to improve on some of the things that these patients are telling you about your practice. A lot of times it's wait time, right? I don't like to have to wait. Maybe you don't have that problem here because you got a beautiful lobby. I don't know if the chairs are comfortable, so I didn't sit down there, but you know, things like that. One of the practices had sort of a walk-in clinic, but there was no awning over the people that were waiting outside the door, and you know, that's a problem. But you let the patients tell you that. You may not have ever thought of that as a problem. It's not a problem to you because you're not getting wet, but it was a problem to them. And so what we want to see is their input and ask them, you know, what's going on and what can we do to improve on practice. And so you may get some feedback from the folks when they do that, but that's important. And most of the practices that did that initially are still doing it because they enjoy doing it. And the people that they called in enjoyed coming in. And you know, everybody wants to be heard. We all want to know that somebody's listening to us. So it's a good thing. And this is just sort of a highlights on that 6. So when we talked about, when we talked about element A, 3 preventative care measures, so here's some of the ones that you know you can think of for that. Immunizations, we talked about cancer screenings, depression screenings, BMI. And BMI is very easy because we see that in meaningful use and we can get that information really easily. The chronic clinical measures, so we got, you know, here the diabetes, heart disease, asthma. And then 2 utilization measures, so like redundant labs, but you all are here, so hopefully everybody's sharing labs, right? And you can see from one place to the other if the patient's going to see another physician here in the group that they can see the labs. Can they see the labs? Imaging, you know, we don't want to overdo imaging if we don't have to. And generic medications, are we pretty good on generic medications in the group? So we can use something like that. I mean, so simple. I mean, we're all trying to prescribe generic medications when we can. And then the vulnerable populations again. So it could be financial, it could be by age, like we said. And then the practice obtains feedback from the families. This is their experience. You can do surveys. Do you do patient surveys? Love those, don't you? So are they electronic?
Yes.
Yeah, so you get the results. And how many people do you poll? Is it just sort of a, if you feel like doing it, or?
It has been if people like doing it.
Yeah.
But we're getting ready to go to a service where every
Good.
patient at checkout, we get a.
Oh, good, okay. So you'll get some good information, and that'll be perfect to use for this one. And then, yeah, so that's good. So, and then that group is helpful as well. So when we talk about the levels of recognition, it's a score. And if you go, if you only get 0 to 34 points, you're not recognized, and you have to do it all over again, which is not fun. Level 1 is 35 points, which is fairly easy because there's 100 total points. So if you do all your pass items and you pass them at over 50%, you're definitely going to get a level 1. Level 2, 60 to 84, and then level 3, 85 to 100. The most points we've seen so far is about 99.5 because we didn't have the ability to send immunizations in the state, but now we can, so we can probably get it perfect if we wanted to. It's not hard. The point structuring is interesting. This is NCQA's point structuring. The BQPP from Blue Cross has their own point structure. But this is how you would determine whether or not you got a level 1 or 2. And what's important about a level 2 or 3 is if you can get a level 2 or 3 coming out the first time out, hopefully you'll get a 3, you get a level 3, that's the highest level you can get, and you're good. If you get a level 1, if you don't get up to a level 2 or 3 within that 3-year period as you've been recognized, you have to go back the next time around and do all the same thing, all the things again. Like all the standards, all the elements. If you get a level 2, you only have to do a certain proportion of that work. So it's really, really advantageous to try to get in there at a level 2 if you can. And for some people it means more money because they're at a higher level. So NCQA is the site, and it's at ncqa.org. And then the BQPP program is over at Blue Cross, but CCNC also offers some incentives. I think Aetna's offering some incentives now as well for patient-centered medical home. We know Medicare is all about patient-centered medical home. And the ACO environment, if you're looking at that, is actually, you know, all based around the patient-centered medical home model as well.
So is there a set period of time you try to accomplish all this, and then you go to a certain level and you renew it every so often?
Yeah.
Or once you get there, or is
Yeah,
it
good
static?
question. Yeah, so once you get your level, so
And you
we're
have
working
that all
on it now.
completed, like
Oh,
a year?
you can continue working on it. You probably want to do it within a year because there's a lot of reports they're looking at that they want to look back 12 months. So if you get too far out, now your reports are old. So 12 months, I'd say, 12 to 18 months. once you get that level from NCQA, it's good for 3 years. So if you get a level 3, you're in for 3 years, at 3 you're good to go. And it stays that way. About a year prior to that 3 years being up, you want to start looking at what's the next thing. What are you going to ask me for now? So then you're going to look at that. Right now, there's new standards that are out for they call it the 2014 standards, because these are the 2011s that have been out for 3 years. And the 2014 standards are out, and those will be effective as of January of 2015. So if you didn't already send your patient-centered medical home information, and by that time, you'd have to do the new standards.
So therefore, our goal is to submit at the end of this year,
Yeah.
fall of this year, so we don't have to.
It's like
Follow
meaningful
the
use,
new
every
standards.
state, they add something more to it. I understand meaningful use is great, everybody's met that. There's a great deal of meaningful use reports that we'll be able to use on this, so that's good that you've already done that part of it, because now we already have that information. And what you saw with working on meaningful use, is sort of the same thing we'll see with patient-centered medical home. There's certain things we're going to have to remember to do for our patients in order to meet the criteria that the girls are trying to get the reporting for. So it's all good. I think you'll enjoy it if you like this kind of quality initiative. It'll be enjoyable. Is there any other
Not to
questions?
mention it has a financial impact to you as well.
Huge
So.
financial. Yeah.
What's the price?
Well, it depends on the level and our tier, but it could be anywhere from 5% increase on your E&Ms with Blue Cross, right on up to some practices seeing 30% increase.
We were talking earlier, they did the pay for performance in California, and everybody invested all this money, and their rewards were measured in hundreds of dollars, not thousands. People lost money, so there is adequate reward to reimburse us from us.
Oh, yeah, absolutely, absolutely.
And that's just one payer.
Yeah.
Usually Blue starts it and then everybody else decides that it sounds like a good idea, right? And then they'll follow through on it. So.
And is this something that will be done in the primary care area or all
Yeah.
across physicians?
This is just for primary care. They did come out last year with PCSP, which is for the specialists. So our goal is to do primary care, because once we meet these standards for PCMH, a lot of that will lead us into the PCSP. So that's what we'll follow. Hopefully, we get this done. Next year, we start on the specialists, and then they'll see the exact same advantage, because the Blues are moving towards reimbursing them the same way, increasing reimbursement for them as well.
So y'all will look and see what we've already done that can qualify for meaningful use and figure out where the holes are. And tell us
Right,
what we need.
and that's kind of what Heather and her group's doing right now. They're kind of looking at what you're already doing, not changing anything, writing a bunch of policies on what we are doing, just so we have a written policy, and then trying to figure out where we have the holes, and what we need to do to plug the holes, what we need to change. And a lot of it they're finding is tweaking some of the templates that you're already doing, just adding a couple of questions in the templates you're already doing, kind of like we would do with meaningful use. So I don't think it's going to be a huge workflow change for you at all. You might ask an additional question for this patient or that sort of thing. I think that one of the biggest challenges is identifying the conditions, what you guys feel comfortable with, what you're seeing the most of, what you feel like you follow up on, and then closing that gap on the follow-up of referrals. I think that's going to be one of our kind of questionable things. But I think we'll be okay if we can just look at internal and not use the external referrals.
And you enrolling this all as a group, or you have to as a group?
You know,
It's all or none.
when we were residents, a bunch of us over at the hospital, and we were doing guideline-based diabetes, hypertension, that kind of thing,
Mhm.
there were templates through Centricity that had the JNC guidelines for hypertension, had the 10 parameters we needed to meet for diabetes, and there were the CCC components of Centricity, and that's not what we're using here. But we had guideline-based things, and it would pop up the guideline, and you would have these little, and if you didn't fill it in, you were blank in that area. It was very clear what the guidelines are for hypertension, diabetes. You remember all that?
Yeah, it's like when we have the 10-year cardiovascular risk, the little, it feels,
It was like all.
basically
Like a
you just have to
template.
click
Yeah.
you just have to put in the blood pressure, which I don't understand why it doesn't populate automatically, because we have it there. So that automatically gives you the 10-year cardiovascular risk, and then you decide it based on the averages.
So they were very
we
easy
have some
templates
of
that
that stuff already.
it was like filling in little boxes.
And then
You can
the
update
next
this
up
also.
upgrade, yeah, the next upgrade that we do with Centricity will give you CCC forms free. I mean, it's part of the package, so we can certainly spend some time working on.
Is that
And
this
that's a
year?
good
That's
point,
not
Seth. I'm
free.
glad you're saying that, because we're up, our plan is to upgrade in April of this year to CPS. We're not gonna do any of this support documentation until we upgrade to CPS. We're kind of waiting on that because of the forms that will be added. It will, yeah, plus CPS is a certified EMR, so that,
If that's within this year, I mean, I imagine there are guideline-based CCC templates that address 3 chronic conditions. That would be very straightforward, and we wouldn't have to create anything. We just use what's already there.
so am I right, Heather? Your
Right,
plan is-
and also the care plan that we'll have to develop is something that's gonna be available to in CPS for us.
So we don't have to redevelop the wheel. It's gonna be there when we upgrade. So hopefully if we upgrade in April, you guys get accustomed to the system, we can start collecting the data in June. Wasn't that the plan?
Right.
June, so we could do maybe June, July, August, somewhere in there, and then submit in the fall. And that way we submitted well before the new guidelines come out.
So this, can we use this when we do our recertification for boards exam as a practice improvement things that we have to do? This will count.
You just have to pick
Because
a-
it's this type, like for family practice, a lot of it is the same thing, like the influenza thing, yeah, the same thing.
And you just have to pick the patients, because you have to.
Yeah,
fill
you
out
just pick the
information.
patient and
You have
then
to-
report on this.
not only
You
the
just get a
patients,
report and give it to them too, it's the same.
When,
Good question.
when you're seeing the increases from, say, Blue Cross Blue Shield, what range of codes are they, is this increase applied to?
It's across the board is what I'm understanding.
Well, that's what I thought too. And maybe the physician I was talking to didn't understand, but a physician in another practice said to me, while they are level 3 and they're getting the increased reimbursement, they're not getting it on their labs.
I understand that they're their E&Ms.
I did too.
Okay.
And we actually ran a report to see what just your Blue Cross reimbursement was last year, on just your E&M codes, and I have it broken down by doctor if you want that, so you guys can take a look at exactly what your blues for your E&Ms were, and can kind of calculate what that could amount to for you.
Had you talked to Joy Simmons over there about it?
Yeah, I did. I haven't talked to her recently. We talked to her when we first started this, and we are, the tier we're on now, we are eligible for the PQPD, so
Okay.
we did establish that.
Yeah.
So,
And then it was all E&M codes across the board, I believe.
yeah,
Okay.
right.
Although it might make sense that the labs would not be included.
Well, I'm wondering if it's like the primary care incentive bonus, where it's if you have more labs than you have office visits, we have a little bit of that going on. But he was saying lab was involved somehow. He didn't really understand how, but.
Now, Joy explained it to me that it would actually be a increase in our tier for our reimbursement. So it would be a direct per
So they're not going to
CPT
look and
code.
see what percentage you are?
No,
What? Okay.
that's not the way she explained it to me. It would be per code.
And
That's
are
my understanding.
you seeing that same thing with the other insurance
I
companies?
don't really see what they, the other insurance companies, I don't really know how they're calculating the other
Okay.
insurance companies. I don't even think CCNC, I'm familiar with what they're doing, the per patient per month kind of thing. But the other ones are just now, I think Aetna just announced that a couple months ago, so I haven't seen.
Yeah,
I can get
seen
somebody
anything
to look
official.
into it and find out what they're looking for.
Which we have such a small amount of that now,
Mhm.
that won't have a huge impact. Definitely not like the blues will.
Yeah. So, there you have it. Any other questions?
There's no advantage to Medicare patients from this.
Not yet. Not yet. But you know it's
It
coming.
will be.
Oh, when they're talking fixing the SGR, which everybody is, that this is it. That clearly they're gonna have some sort of performance.
And I think, they're going to that quality-based reimbursement, talking about that for 2017 or 18.
Value-based modifiers, yeah.
Yeah, so I think that's where this is gonna play in with the Medicare. We'll be prepared for that by doing this.
Yeah. You'd rather be ahead of it than behind it, that's for sure. And I just think that, and I think as the practices that have gone through this will say, if you stick with it, you continue along the same, way of doing things. And you've already seen some of the things that you're hearing, that you've already done that have improved upon patient care with things that are popping up. So if you think about your patient population, is there something you wish, you could do a better job of? Maybe there's some way, the woman coming in and looking at the Medicare patients for those particular vaccines, right? Is it vaccines that she's looking at? Or is there, is there something that we can spend a little bit of time up front on that's gonna help all of our patients as we move forward? It'll be interesting when we get the electronic immunization registry, because then you'll be able to get that information as to who needs what shots when. Pretty nice. Fine.
Well, Terry, thank you so much for
Oh, you're welcome.
taking the time to do the
You're welcome.
presentation for us.
Hopefully that helps. If you have any questions, they have my contact information. I'd be happy to answer it for you if I can. And the girls here are doing your policies and procedures and getting things ready for you, so it shouldn't be too difficult.